evening. I can see that we are already intoxicated badly. We need to go for a tea. But before that, I think we need to finish the plenary 4. Plenary 4 is about heart failure. I think this is a topic that matters a lot for the general physician, the internist, because we see a lot of patients getting admitted to our ward. So I'm sure the lecture will give you some information and some new information. And to talk on this topic, we have Dr. Adri Kok, a South African physician, who is currently the president of the International Society of Internal Medicine. So may I invite Dr. Kok to start off the talk on heart failure.
Thank you very much. I'll talk quick, then we can get to tea time quickly. Thank you again to the faculty for inviting me to present this talk. And I think heart failure again is a worldwide problem. If you look at, so it's just my disclosure slide. If you look at the typical presentation of these patients, again, it can be a patient who really can't breathe, they sit up at night, or the patient that comes to us in gross edema with anasarca, like the picture on the right-hand side. We look at obesity, which is a problem especially in the Western world and definitely a problem in my country. And I always think of these little devils that attack the heart. So it's obesity, an epidemic of type 2 diabetes, which is occurring around the world, hypertension, and dyslipidemia. And I think if we look at how these are attacking our patients, it really is an understatement to say that cardiovascular disease is one of the biggest killers in the world today. Definitely in South Africa, this has become the #1 killer. I've put up this slide about smoking, and we've just said about smoking improving in some countries. And the reason why you look at people with smoking, which is just an additional cardiovascular risk factor, it really just continues to deteriorate. So even our surgeon who spoke earlier on plastic surgery, I don't think could do anything for this person. Smoking, stopping smoking, of course, is absolutely crucial as far as cardiovascular disease is concerned. So if we look at heart failure, it is increasing in prevalence, and of course with age, this is again one of the situations where age has a definite role to play, and this is true both for male as for female patients. And what are the outcomes? We can either have a patient who is bedridden, or then ultimately death, which of course is what we try to avoid. Now, one of the points that I think has come to the fore more recently has been the patient that we consider to be stable. So we think the patient's stability has been achieved. But if we look at the Paradigm study, which was one of the more recent, very large studies on heart failure management, it showed that some of the costs are also related to a patient that we consider to be stable, that they actually have many outpatient visits, but also emergency department visits. So a good number of the patients that we consider to be stable actually are not, and we could improve them. So they might have mild symptoms, but if we look at the overall presentation and the actual classification of heart failure, they are not stable, and actually their medical progress can be improved if we address the underlying problem. We also have to understand that the patient's perspective, they have to live with this disease. They have to come to the outpatient department, they have to see the doctor, they have to wait in line for their medication, but more importantly, they live with the symptoms of heart failure every single day. If we look at some of these symptoms that really impact, they feel tired all the time, they can't walk far, they can't do their normal activities. The physical limitation is massive. Sometimes they are dependent on others to get them around. They have to sit in a wheelchair. Their quality of life is actually shocking. And this may interfere with how well they can actually live with their families, their friends. Can they go out? For example, if it's an older person, they may be stuck at home because they're simply too tired to move around. And all of these should be borne in mind when we look at the management of these patients. It's not a simple thing just to say, well, you've got heart failure, here's some tablets, let's see how things go. You have to understand that if you have something that can improve that patient's outcome, we should not keep the patient from that medication. So when you consider this stable, what we call a stable patient, from the Paradigm study, and John McMurray was the main author, that if you look at the patients, 33% of these patients needed some kind of intensification of therapy because they were frequently readmitted to hospital, they had frequent acute exacerbations. And of the patients in the study, 61% of them had a sudden death episode. So they were considered to be mild heart failure or stable, but 61% of those who died had a sudden death event. So we may not even see these patients again, they just don't ever come back to us. And we lose contact with them, but in fact, they passed away at home and never got to our attention. So it's important, I think the message is that we shouldn't underestimate heart failure and understand what a severe disease it is and how it impacts on our patients. So it's really this myth of clinical stability that we consider, that patients with mild symptoms are not stable, they may progress rapidly, even if we consider them to be on optimal therapy, with over 11% of patients which were in the enalapril group in Paradigm exhibiting some manifestation of worsening. It's also important that symptoms may then related to the quality of life in those patients, and in 33% of patients, the first manifestation of progression or worsening of their heart failure could be a sudden death episode or cardiovascular death, which is preventable. So this is a threat to our patients, our perception of whether the patient is stable or not and how well they are controlled. Now, interesting enough, whatever we say about the recent American president, that was a joke, guys, it is late in the afternoon, I know. But if you look at the presidents over the years, in fact, it's not a good idea to be an American president. So you either got shot or you died of heart failure. So I think what is important here to understand is that, again, a high-risk type of job in the sense that you have a high risk of cardiovascular disease, heart failure, in some of them congestive cardiac failure, and stroke. So when we look at the new the new guidelines on the management of heart failure, it is important, first of all, to look at whether you suspect the diagnosis. I hope this projects okay. If it's not, you can use your proBNP to assess the severity of it. And then once you've confirmed it, you have to go to echocardiography. And I'm not sure how easily that is available in Sri Lanka, but again, in South Africa, this may be limited to some of the major centers rather than being available everywhere in the country. So in some of our rural areas, those patients would have to come to a major center to be investigated and to be properly categorized before treatment can be commenced. And it's not just about how well does the left ventricle work. There's also about whether there's preserved ejection fraction, if it's a mid-range, or whether it's a reduced ejection fraction. We can have patients who have acutely decompensated heart failure. We can have patients who are chronic stable heart failure, so-called stable, the very acute onset, de novo heart failure, and then patients who have advanced or refractory heart failure, as in the picture that I showed at the beginning. And those are really the most difficult patients because there's such a limitation of what we can actually offer them in the long run. If we then look at the definitions of heart failure, there's also criteria that goes on symptoms, the left ventricular ejection fraction, so if it's less than 40%, this in-between group 40 to 49%, which was again discussed at the European Society of Cardiology recently, and then the ones with preserved ejection fraction where it's above 50%. So that in-between group is difficult, but again, your management would really cover all of these groups adequately. So when we look at this, this is the pocket guideline for heart failure with a reduced ejection fraction, or so-called HFrEF. If you look on the right-hand side, we now have additional medication that can help these patients function better. So if they can tolerate an ACE inhibitor or an angiotensin receptor blocker, the alternative now is that we can have an ARNI, which is a neprilysin inhibitor combination with an angiotensin receptor blocker, and I'll discuss that just now. If there's a prolonged QRS interval in these patients on their ECG, again, evaluation should be done for cardiac support therapy. And if the sinus rhythm is above 70, ivabradine should be considered, and I'll go through these in a moment. So the RAS system and the interaction with the sympathetic nervous system in heart failure absolutely underpins the basis of therapy. So on the one side, we have the natriuretic peptide system, and of course this drives many of the symptoms that the patients experience. We have the sympathetic nervous system, and we have the renin-angiotensin system, which we have known from when enalapril was the first ACE inhibitor to come to market, to be very effective in the management of heart failure patients. And if you look at the interaction of these three systems, the development of the newer medications would make perfect sense to us. So just going back to the landmark trials over time that have really changed our management as these agents became available. The first was the SOLVE trial, and that's way back in 1991, which is the year I started working in private practice after qualifying as a physician. Then came the CYBUS trial with the beta blockers, the CHARM study with the angiotensin receptor blockers, the CHARM advanced added study, the SHIFT trial, which was with ivabradine. The PARADIGM trial was the most recent, and emphasis with the addition of heart failure treatment in 2014, looking at loprednone. So I think the way this has developed over time, each time we realized we're not really getting our patients completely better or under control. There's always been this opportunity or risk of worsening symptoms. And then the new agent has come along, and then another agent has come along. And all of these have actually added to saving lives over time. If you look at SOLVED in 1991, you can see 15.6 down to 12.4%. Then the CYBUS and MERIT-HF trials, 11.9 down to 7.8. And with the EMPhASIS trial, it went from 7.06 to 6.09. So it's become more and more difficult to make a difference because we've just become better at what we do. If we then look at the guideline, again, the evidence that we have available is massive. So there's class 1, level A evidence on all of these suggestions. So the treatments that we have available to us. And this is really fantastic to have this level of evidence, and we see the benefit of these treatments in our patients with heart failure. And it's important, it's not one agent that will make the difference. You have to actually use several agents because we have to address the whole pathophysiological profile of the patient. It's not one aspect only that we have to address. If we look at symptomatic treatment, again, we know that with diuretics, they don't really make a difference to outcome, but they do help symptoms. We know that cardiac supportive therapy with a assist device may make a big difference if the patient has a prolonged QRS interval, and that the agents like ivabradine, which has not been available in every country, really can make a difference also in the patient's effort tolerance if their heart rate is above 70 beats per minute, and if you can bring it below that, if the patient is already on a beta blocker, you would add the ivabradine to that treatment to get to the best result possible. If we look at CRT, again, this has been a lifesaver. Again, not widely available in the world. It depends on the health system whether patients have this ability to receive these agents. This is an implantable device that really worked to assist the heart. And again, with a prolonged QRS, of course, there's a risk of a sudden death with arrhythmias. And by using this, you prevent those arrhythmias from happening. And this has really been the resynchronization therapy that has become available has saved many lives. As you can see, the CARE HF was the first one that showed the benefit and the improved outcome on that side. If you look at the SHIFT trial, this showed the outcome improvement with ivabradine, and it was an 18%. Now, the placebo arm in this trial, again, is good therapy, practical therapy that was implemented with all the available agents available to us, and then ivabradine was added to the patients where the heart rate was above 70, patients in sinus rhythm, not in atrial fibrillation or any arrhythmias, and they showed a further 18% improvement in those patients with ivabradine. So each time we've had a new study come along, we've seen the improvements that are possible. If we look then at the newer agents on the block, the sacubitril/valsartan combination, this is the ARNI. It works on the two agents, two pathways, especially on the side of the natriuretic peptide, which is one of the ways that we diagnose heart failure. We can now intervene on that pathway using the neprilysin inhibitor. So you have the benefits of vasodilatation, whereas on the other side with the angiotensin receptor blocker valsartan in this combination, it works on vasoconstriction, and the two actually work in tandem to improve the efficacy of how well the heart works or doesn't work. And if we look at the paradigm study, which was done with this ARNI or the neprilysin inhibitor angiotensin receptor blocker combination, it was really one of the largest geographically widespread studies of all time, to really include 8,442 patients, and you can see the number of countries that were involved in this trial. And what it showed us, that if you look at what we had before versus now, where we're adding this neprilysin inhibitor, there was an incremental benefit. Looking at this, I just want to move if you look at there, you can see that with this combination that you had an incremental benefit in helping these patients versus what we had before. So there's an augmented benefit to these patients with heart failure, which was not present before. So we know about diuretics. This is patients from both 2 to 4 class, New York Heart Association, the ARNIs, the IF channel blocker, the ivabradine, and the angiotensin receptor blocker. And there are specific guidelines on sacubitril/valsartan, which is important because, again, you have to stop the ACE inhibitor if the patients have been on it to avoid angioedema. It's contraindicated in pregnancy. It has to be titrated slowly, and there are various precautions to be taken. So it is important. You can't just one day decide now you're going to use this agent. You have to be really careful with how you implement the agent that you're going to be using. I don't know if it's available in Sri Lanka. It's called Entresto, and I'm not sure if it's available in Sri Lanka, but it might be something that would be coming. Then just to change tack a little bit, I thought just to bring some guideline on acute heart failure, and just to show you the difference between these two. On the left-hand side, you can see a patient where there's a long history of chronic heart failure, 3 weeks of gradually worsening symptoms, blood pressure of 85/40. And on the right-hand side, you can see this real concentric thickening of the heart due to hypertension. It's an 80-year-old patient, 1 hour of sudden onset of symptoms. Blood pressure is actually elevated, 185/120, so an acute hypertensive crisis. And you can see the X-ray that goes with it on the bottom side. So if we look at the disease of acute heart failure, this may be on top of chronic heart failure. Usually it's the elderly patients, a mean age of 75. 40 to 50% of these patients actually have preserved ejection fraction, so their left ventricle is not the main problem. Common comorbidities include, of course, type 2 diabetes, chronic kidney disease, atrial fibrillation, and most patients have a normal or an elevated blood pressure at presentation, and most of these are related to signs of congestion, when they present to the emergency department. And you can see that decompensated heart failure, looking at the clinical profile, 65% of these patients present with decompensated heart failure, 16% with pulmonary edema, hypertensive-related 11%, cardiogenic shock 4%, and right heart failure in about 3% of patients. But I'm not going to go through this algorithm, but just that there's an end organ dysfunction, there's congestion, you have myocardial factors, renal factors, vascular and neurohormonal factors, and all of these need to be borne in mind. So is there an acute coronary syndrome? Is it a hypertensive crisis? Is it an infection? Is there a renal problem? Is it maybe non-adherence to medication? So there could be various factors that you need to interrogate when you evaluate these patients. And to understand, again, the mechanisms of what adds onto this, I think this just shows it more easily that they may be sympathetically mediated, and on the other side, renal and dietary mechanisms, venous reservoirs affected, sodium and water retention, which we heard about this morning. And so you may have symptoms that develop in seconds, and you may have other symptoms that more develop over a few days in these patients. And it's a complex system, so you have to understand, again, in that particular patient that comes to your emergency department, what could be the reason for their presentation. And really to understand that you have to really sometimes just look at a case. This is an elderly 74-year-old man. He arrives with high blood pressure. He's got features of congestion. He's treated with a loop diuretic. He presented with dyspnea at rest, peripheral edema, raised JVP, and as you can see, a pro-BNP elevated at over 2,000. That's his ECG. This is his chest X-ray. And again, he shows evidence in his situation of diastolic dysfunction with no regional wall abnormalities. So again, as we go through non-cardiac causes, whether there's an infection, was it his therapy, are there other cardiac causes that could have caused this? Is it arterial hypertension? Or are there pulmonary causes that could have precipitated this acute event? So in him, the idea would be you must alleviate his immediate symptoms, reduce the fluid excess or the congestion, improve the hemodynamics, maintain his renal function, make sure that organ perfusion is normal, and worsening of the underlying disease is important. Because it's not just that event, it's also what comes afterwards. And I think this is what we see that these patients are, we call them a revolving door. You were talking about off legs earlier. Well, this is a revolving door type patient. When you look again, they're back. Same problem, and every time when they come, they're more decompensated, they're sicker, and they get to the point where eventually, of course, death results. So it's important that we try to find a mechanism where we can identify these at-risk patients and then find a way that we avoid they're being readmitted to hospital all the time. And this may be a situation where nurses in the community could do home visits or at least get the person to a clinic closer to their house to be able to monitor, especially their adherence to therapy and avoiding these episodes of acute exacerbation, sometimes just from fluid overload because the patient didn't understand that they must restrict their fluid intake. So if we look at the current therapy in acute heart failure, again, there's a patient who has a high blood pressure. They may need vasodilators. They need nitroglycerine. They could have a normal leash blood pressure, systolic blood pressure. They could use either vasodilators or inotropes. And then the cold patient, the preload restricted patient who might need inotropic agents to improve their hemodynamics. So in this particular patient, again, in him, it was a hypertensive crisis that caused the problem. And it was in him, again, a change of his medication because he went from the physician to the general practitioner. There was no communication, and the general practitioner didn't know what chronic medication the patient was supposed to have, treated him for acute chest infection, and did not continue the failure therapy, which then resulted in the problem. Also gave him an anti-inflammatory agent for influenza, and this resulted in worsening of his kidney function, which then caused the problem. So he responded very well to furosemide with nitroglycerine. His normal therapy was then restarted. But again, in this situation, this may be a patient that previously was supposedly stable. If you can just see what caused this acute exacerbation, again, the newer agents like the ARNI might be indicated in this situation. If we look at these repeated admission type patients, again, worsening heart failure over time with these repeated admissions is really a recipe for disaster. So these patients tend to eventually land up with a high mortality rate, and often much quicker than people that are well controlled. I'm not going to go through all of these, but just looking at some of the guidelines, looking at how do we manage these patients, to have an approach to them. I'm quite happy to make these slides available if doctors would like to see the detail, because I think it's quite a nice approach to have this kind of algorithm. And just in your mind to have a way to actually look at it. Is the patient wet and warm? Are they cold and clammy? Are they hypoperfused, hypovolemic, or are they hyper-overloaded? And then to look at their systolic blood pressure to decide on which side of the algorithm you're going to focus to look at your management. Also importantly is the management of comorbidities in these patients. I think we cannot stress enough that many of these patients have multiple comorbidities. They don't just have one. So you cannot forget about the elderly patient that is frail. It's very easy to prescribe a diuretic, but you have to keep in mind that that elderly patient may be incontinent as well. So it's a very fine balance to be able to do adequate diuresis without causing undue harm with the diuretics that you prescribe. They may be too frail to get to a facility where they can actually relieve themselves, and this causes a lot of discomfort and again have other complications that may occur. We need to look at a team of people, especially in our older patients, to ensure that they are compliant with their medication. They often have diabetes, they may have hypertension, they may be anemic, they might have thyroid disease, and the polypharmacy that we prescribe may be a problem. One of the issues in my country for sure is opioid abuse that is in combination therapies in painkillers, which again I think it's a huge problem in the Americas as well. So it is something that patients don't always understand, that these agents could have a negative effect on how they're feeling. So it is important that we again educate our patient, that they understand what we're prescribing, why are we prescribing it, and how can they look after themselves better. And that team approach must include the patient's family, the patients themselves. It's not a simple thing to just give a prescription and then think that the patient will understand exactly how their medication is supposed to work. We have to spend time to educate the patient so they understand what the medication is all about. And again, when they have symptoms that affect their quality of life, that they rather respond to these early than to wait until it becomes an emergency situation. Thank you very much.
Thank you very much, Dr. Kok, for that very comprehensive lecture on heart failure. I'm sure everyone must be dying for a cup of tea or coffee, but I'm sure Dr. Kok would not mind taking a few burning questions, one or two.
I think this is a thirsty lot.
Yeah. Yes,
I have one question. Since you come from a country which pioneered the heart transplant about 50 years ago, so I am interested to know that what is the current situation of heart transplant for heart failure, and how about the survival rates in your country?
So our biggest limitation are donors. So they're very much the same as what we spoke about earlier, that there may not be donors available. So we have when the Prof spoke about liver disease and liver transplant. So the very good efficacy, very good immune suppressants available today. We look at the physiological profile of the patient rather than the age. So again, the patient is evaluated very carefully, looking at renal function. I think that's a very important determinant. Comorbidities, if they're diabetic, it becomes more difficult because of the immune suppressive therapy. And the mechanism of the heart failure, of course, is important. So the majority of the patients are mainly young patients with cardiomyopathy, especially viral myocarditis, would I say would be the commonest. They would be sort of first on the transplant list rather than a very older patient, much older patient. Very good success. We do heart lung transplants as well. I'm not at a transplant unit, but the one that we have in Johannesburg, for example, the success rate, I don't know the actual figures, but just from from hearsay, that their success rate is good. The longevity, again, not able to give you exact figures, but I've seen some patients post-operatively 10, 12 years down the line with very good quality of life. But the limitation is we don't have that many donors. There's a question, Dr. Rugapachi?
Thank you. That was an excellent lecture on heart failure. Is there any evidence on ivabradine as add-on therapy to the full gamut of other treatments?
Yeah, I think the SHIFT study, the ARNIs weren't available yet. I think from John McMurray's group now, he's had most of the experience with the new agent. And they use it much earlier now because they've seen such great benefit. So in the Paradigm study, it was sort of add-on therapy. There's not been a study where it's done versus ivabradine on or off. So it's definitely been a stepwise add-on. Ivabradine is only for the patients if the heart rate in sinus rhythm is more than 70. So they don't differentiate whether, it's still part of the pathway. So if the heart rate is above 70, despite good beta blockade, and that's the tolerated beta blockade, you should titrate the patient to the maximum dose that they can tolerate. And these would be your beta-1 selective beta blockers. Ivabradine can be added, and that's where the benefit was shown. So if the heart rate is below 70 and they're well controlled, it would not be indicated. But even in those patients in the Paradigm study, the ARNIs made a difference to their symptomatic improvement as well as objectively to their clinical functioning. So it's sort of a step add-on. And also the stepwise, the other point he emphasizes, it's not wait until it fails. It's like diabetes. You would rather treat with combination therapy early, get it under control. So you would almost want to start a combination early, get the patient under control, depending on how well they tolerate the medication. But I think the ARNIs, if they become more affordable, which will be helpful, again, would be agents that will make a huge difference to these patients.